doesn't eat clowns?
Not relevant.
Because they taste funny. What do you call fish without eyes? At that stage. Ooh. Alright. Alright guys, I'll be presenting hepatitis C virus. We're going to do an overview and also the treatment. I'm Jerry, Huang. I'm from St. John's Pharmacy intern, Pharmacy candidate, 2013. Already Montana with a CVS. And the site was last updated in February 2012. So anybody can tell me what hepatitis C is? What's hepatitis C?
The infection of your liver by a virus.
Exactly, so it's a hepatic infection, right? So there's hepatitis A, B, C, D, E, and so on. So when they discovered hepatitis C, they don't know what to call it. They're like, oh, so it's not A and it's not B, so we're gonna call it non-A, non-B hepatitis, right? And then later, in 1989, because I was born, they called it hepatitis C. Great achievement. So it's an envelope RNA genomes. It's a virus, and it's actually one of the biggest ones when it comes to size for all the hepatitis. Incubation average days are usually around 15 to 160 days. Average 50 days. You can start seeing the hepatitis C coming out after you get infected. Mostly people are asymptomatic after the acute infection. That's why nobody can really tell unless they get tested for it. And we're going to tell which group are the highest in getting hepatitis C. Usually you see elevated ALT. Incident for acute liver failure is less than 1%, but when you do have the liver failure, it can be really severe. So like I said, there's a total of 6 genotypes. In the United States, we mostly have genotype 1. There's only 1.8% of the entire US population that's being affected. 1.8% is about 3.9 million or close to 4 million people that's being chronically affected. And every year we have 230,000 infected. Almost 85% are due to after blood transfusion. That's how you used to acquire hepatitis C. But after early 1990s, the blood transfusion induced hepatitis C has been reduced. So now the new risk is injection drug users, and the risk could be as high as 90%. So this is a global distribution of hepatitis C virus. As you can see, in US, genotype 1 is the predominant, and also genotype 2. And the worst thing about that is that genotype 1 is the worst one to treat. Worldwide prevalence. You don't really see it in like the poor country, sort of. Mostly Egypt, Mongolia, and also I think that's Liberia. Not sure. And also Romania, and Europe. The thing is, these countries are the countries that often reuses the like the needles, syringe needles. And when you reuse the needles, you have high chance of being infected. And injection drug users, like other type of people, usually they're being affected, and that's how you acquire hepatitis C. Right? So mechanism of infection: virus gets to the blood. Virus gets taken into hepatocytes, goes through the membrane, goes into the RNA, translates, and transfers. And that's how you end up having hepatitis C. It doesn't spread throughout your whole body, it just stays in the liver and damages it. So like I said, highest percentage, 60% is injection drug users. 10% non sexual is 50%. So that's the second highest. And as you see, the blood transfusion has gone down to 10%. And that's because we started screening all the blood and we do tests before we transfuse it to people. Because like after the 1990s, we started getting the technology, and that's when we found out that it's really not safe to just inject people with other people's blood that they think it's healthy. So who are at risk? Again, highest one, injection drug users. So where do you think you can see these people? Like, let's say New York.
Slums.
exactly. So you will see them in like the poor area, well, in the city, and then you will see them in like maybe the projects. You know, people who are like drug addicts, and then when they don't have that much supply for, you know, not like the high-class drug users, they can waste syringes like whatever. But like poor people who are drug addicts, what the type of people that's taking hepatitis C, and mostly HIV co-infected people. That's another big group. And also people with multiple sexual partners without using protection. So, and or you know, homosexual people without having backstage passes. So those are the people. So clinical features for hepatitis C. Like I said, 70 to 80% of the people are acute VCD infected, but they're asymptomatic. If they're asymptomatic, usually you don't treat them. But acute hepatitis C could go to chronic, and that's when it becomes severe. Chronic, again, it'll be asymptomatic, but when you see that there's a genome in the blood test, then you want to treat them. Because what happens is that as disease progresses, you can get cirrhosis and you can end up having carcinoma. So, major symptoms for acute hepatitis, if they are symptomatic, you see jaundice, and jaundice is probably the biggest one that you'll see. You just see skin turning yellow, really yellow, not like Asian yellow. And also you see the eyes turning yellow. We don't have yellow eyes. Alright, so diagnose. People who doesn't have the antibody against hepatitis C, of course they're at risk. People who do have antibody against hepatitis C, they're either acutely or chronically infected. Several ways that you can test. You can do EIA, you can do RIBA. These are the two FDA approved tests. Other tests are there. Mostly we use the in-house or the commercial assay to do qualitative or quantitative. Quantitative is to see like how many numbers or how much the HCV RNA is. Qualitative to double check that it's actually there. Detection, Q, you would do the hepatitis C virus RNA, that's how you can tell. And also Q, like I said, jaundice would be another sign. Chronic infected, you would use the antibody, anti-HCV, and like I said, you can use ESA or RIBA to detect it. Case fatality, usually you don't die from hepatitis C, you die from the complication. So 1 to 2% mostly. And it is a curable disease if you give treatments. As a pharmacist, we're going to talk about what the treatment is later. 50% can be cured, but 50% is still really low compared to all the other diseases. Just because we don't have that many research into the drugs that we're developing. So, and you do carry on the virus. So if you're a woman and you're giving birth, it could ultimately infect your kid. That's going on. So who should be treated? Of course, people with hepatitis C RNA positive, people with age greater than 18 years old. And usually I haven't seen a patient that's less than 18 years old because, you know, like I said, injected drug users. And also the thing about greater than 18 years old is the drugs that we're treating them. These drugs are highly toxic, a lot of side effects. So we don't want to use them in young kids. And also there's no dose indication for kids, for children. So that's why we usually don't use them until they become fully grown and going to the adult stage. We do a liver biopsy. If they have other compensated liver disease, they will want to treat them. Acceptable treatment would be ribavirin, and acceptable treatment would, you want to look at their hemoglobin. People with anemia with really low blood count, usually that's a risk again for ribavirin because it highly reduces your blood count. When your blood goes acutely, acutely decreased hemoglobin, you're gonna have like all the anemia side effects and it could be fatal to you. It's gonna decrease your blood count, decrease your hemoglobin. You're gonna have hypoxia. Usually you're gonna have less oxygen, carried to your other organs. You're gonna have multi-organ fail. That's why we don't use when people have really low blood counts. And people with serum creatinine less than 1.5. So those are therapy. We want to get rid of the disease. We want to decrease the morbidity, mortality. We don't want want to normalize the marker, but that's just the things that we see to see if they're actually being treated. We want to improve their symptoms, prevent the spread of the disease, prevent progression to like cirrhosis and carcinoma, and also prevent the development of end-stage liver disease. So as pharmacists, we need to know this. If you go on rounds, if you work in a hospital, if you do management, you need to know the standard of care. This is actually the old standard of care. There's actually 2 new drugs, but I'm going to talk about them later. Mostly you would use interferon. Ribavirin is only there if you are using interferon. You cannot use ribavirin by itself. It's an adjunct. They say it has high cure rate, but I've seen studies and they say either. But physician want to be sure, so usually they would add on ribavirin depends on how severe the disease is. Like I said, genotype 1 is the hardest to treat, and in the US we have all these patients. So therefore, they require longer time to treat because since it's hard to treat, we want to focus more and give up more into this treatment. And the worst thing is that hepatitis C, there is no vaccine available. We know there's vaccine for which hepatitis? A, B. Because A usually it just gets by, like it's not that severe, so you don't really need vaccines for it. But they are looking into developing hepatitis C. The reason why vaccine is so hard to develop is because that the surface antigen keep changing all the time. So every year there's going to be a different one, and it's changing more rapidly than like influenza. But what they're focusing now is into the inside engine of the hepatitis C virus. So they're working on it, and it shows you can prevent for 1 year and 41 patients. So we'll see what that turns out to be. ASLD recommendation, treatment can be delayed for 8 to 12 weeks after acute onset. And usually, sometimes it can spontaneously resolve. So all you need to do is give supportive treatment. That's only for acute onset of hepatitis C. Support treatment will be fluid and other nutrition because liver, usually that's what you do. You filter, you synthesize the enzyme, so you want to help with that. For chronic, you would acute. You can also use interferon base, and also people will use Pegasus, which is brand name for peg interferon. It's just easier that you don't have to do this all often. You have to treat for at least 12 weeks. Chronic hepatitis C, you always get treatments. If it becomes chronic, you always get treatments. First line treatment, again you get Pegasus, subcutaneous once weekly, so you don't need to go back to the clinic or do it by yourself all the time. All you need to do is once weekly. And you can also take the oral tablet, ribavirin. So it's just like taking any other dose. Really great compliance. And if you don't see any antibody for hepatitis A and B, you can give vaccine for it. Because when you have hepatitis C, you have higher risk of acquiring those other 2 types of hepatitis. And also, you need to tell the patient to stop taking because it is the liver. And there's no herbal supplements that you can recommend at this time. So again, genotype 1, longer length of treatments, 48 weeks.